Robert McMullen. I'm a psychiatrist. I went to Georgetown Medical School, which was a wonderful place, and I did my residency in psychiatry at Columbia Presbyterian Hospital, which is also a very good place with a lot of great research going on. For the past 36 years, I've been doing primarily psychopharmacology. And then when TMS, transcranial magnetic stimulation, came out, I very soon wanted to acquire a machine because this would be an extra modality to treat people who we couldn't get all the way better with medicines. I got my first machine in October of 2010, and now we have 4 machines, 2 machines in 2 different locations and 2 different types of machines. Now, how does one treat depression with TMS? The basic treatment is to do an excitatory treatment on the left forehead, which is called the left dorsolateral prefrontal cortex. But it's the point of the brain right here. And the way one does this is there are copper coils through which electricity is being pumped at a very high intensity. And this pulse of electricity causes the copper coil to turn into a magnet. And so we're putting a very powerful magnetic field over this spot of the brain. And a magnetic field can go through the skull very easily, whereas electricity cannot. But it's not stopped by the skull at all. So this magnetic field, when it goes on and off, you can excite the brain or you can quiet the brain down. And the main antidepressant treatment for 20 years has been to do an excitatory treatment on the left. And this takes about half an hour. There's usually 20 pulses per second for 2 seconds, and then there's a 10 or 15 second interval where there's no pulses at all, which is mainly to allow the machine to stay cool. It'll overheat if you do too many pulses together. And the entire treatment takes about 30 minutes. And it can feel a little funny, like a woodpecker pecking on your forehead. And if you turn the intensity up enough, since it's causing the muscles on your scalp to tighten up, it could be uncomfortable. But if anybody gets uncomfortable, we just don't go up any higher, we stay low. And then you accommodate to this over a few days, and then usually you can go up to the desired treatment intensity. Occasionally somebody will have a headache, usually just the first 2 or 3 treatments. And we've had 2 or 3 people out of hundreds who became very fatigued from the treatment and would stay fatigued for a day or 2. And that's about the extent of the side effects. The one side effect we don't want is to cause somebody to have a seizure. We've never had one, and it only happens in about 1 out of 10,000 treatments. And it would be more likely to happen in somebody who's got a history of bad head injury or history of seizures. And if you did the treatment, instead of doing it here, you did it further back on the motor strip. That's the easiest place to induce a seizure. So we avoid doing that. Usually by 12 or 15 treatments, we're seeing some benefit, that the person is beginning to improve. And we have them fill out scales, self-rating depression scales, and then I also do a scale. And if the people are steadily improving, then it's probably working. Sometimes the patient doesn't feel any better, and they say, it's not helping me, even though their scores are getting better, even though they are doing their own scales and the scores are getting better. And that's because sometimes the last thing to get better is how you feel. The depressed feeling is the last to get better. So even though they're concentrating better, they're doing a few more things, and they have a little more energy, and they're enjoying food a little better, and their appetite's a little better, they're not feeling better. And we explain this, and then we continue on the way we are going. And usually we think of about 30 treatments as being the amount most people need for their treatment. Some people get completely to a normal mood in 15 or 20 treatments, and then we may just stop there. Or we may decide to do a few more treatments with the idea of cementing in the benefit. And if there's no benefit by 12 or 15 treatments, then often we think of changing the parameters and doing the treatment differently. For example, beginning to do treatment on both sides, or to switch from an excitatory treatment on the left to doing an inhibitory treatment on the right. And there's a few other new parameters that have been introduced, different places and ways of treating depression. So we have quite a few alternatives. If someone is overly stimulated by a left excitatory treatment, like their thoughts begin to race and they can't sleep and they're feeling kind of hyper, then they're probably a little bipolar. And then we switch and do an inhibitory treatment here. Over the years, the treatments were mainly done left excitatory, and that's primarily because the first treatments were done that way, so everybody continued to do it in the same place in the same way, with some changes, like doing more pulses per second or doing more total pulses. So the parameters were improved over time, and there weren't that many studies on using right-sided inhibitory treatment. But it turns out that the right-sided inhibitory treatment works just about as well as the left excitatory. And I have treated a large number of bipolar patients, bipolar 1, and then people with a mild bipolar problem called bipolar 2, with just the right-sided inhibitory treatment. And it's helped their depression, and we haven't caused anyone to cycle. We haven't made anybody cycle up into a mania or another thing that a stimulating antidepressant treatment does, whether it's medicines or TMS. That stimulating treatment can cause people to cycle more. Maybe they don't go into a high, but they start having more depressions and more agitation, and you're actually making them worse over time. In fact, you see this frequently in bipolar 2 people who have had very few highs and very mild highs, so no one has really recognized that they're bipolar. So they're put on an antidepressant, and the antidepressant works really well, and in a month or two they're doing great, and the psychiatrist thinks he's a genius. And but then in a few months the medicine poops out, and they raise the dose, and it doesn't help much. In fact, the person might get worse. So then they take the patient off that medicine, they try another antidepressant, and the same thing might happen. Initially some benefit, and then lose the benefit. And eventually they're getting no benefit at all from any antidepressant they had. That person is not responding because they are a little bipolar. And so they should be put on Lamictal, lamotrigine, which is an anti-seizure medicine It has a great antidepressant effect. And maybe a small amount of lithium. I always go very low. And then when you use TMS, you use a right-sided inhibitory treatment. And we've had the experience that not only do we bring them out of the depression, but we stop their cycling, so that people who were cycling between moderate depression and agitated depression and up and down, or cycling from depressions into mild highs, that the cycling has ceased, as well as bringing them out of depression. And that's quite an improvement. What's really important is not only to get them to normal, and the goal always has to be to get to a completely normal mood where they feel 100%. And to maintain that, you need to stay on antidepressants usually, or some medication rather, whether it's Lamictal or a tiny amount of lithium or some combination of antidepressants. So usually the medicines that are working partially, we leave them on those medicines during the treatment, and that seems to raise the odds that they'll come out of the depression. Now, and we also use this to treat Parkinson's disease and OCD, obsessive compulsive disorder, and a few other things such as migraines and chronic pain syndromes. These are off-label treatments, but they often work extremely well. If you have any other questions, call me at 212-362-9635, 212-362-9635, or go to our website and read what we have there.